And I was completely closed off to people like you before that.
Yeah.
Because I had such a bad experience with the VA that through a cognitive therapy that I just felt like I just get exhausted by it. And then I met this lady at the VA, and she said and basically had asked me to do if I wanted to do cognitive therapy. I said no, I didn't want to do it again. And she said, well, yeah, have you ever thought about prolonged exposure therapy? And as she started to explain it, it sounded a lot like the perspective, not the same methodology, but the same perspective that I would have from biblical counseling instead of like fun. So I'll explain what I mean by that, because what I look at cognitive therapy was, and I could be wrong, I'm not a psychologist or psychiatrist. I'm neither. What I looked at cognitive therapy from being a patient was that they looked at a situation I was dealing with, a problem that I was having, saying, let's find something to blame it on to offload that burden from me. Like the Sigmund Freud, tell me about your mother, tell me about your father. Let's find somewhere external of you to blame that on, to take that weight off of you. Where I felt like the biblical counseling that I had received was, and I got trained in through the American Association of Christian Counselors, was, it doesn't matter who did what to you, what happened to you, how do you take responsibility for that to move forward in a healthy way? So it's acceptance responsibility. It was, it was
like
different.
inverse, yeah.
And so the prolonged exposure was like, yeah, it doesn't matter what happened to you. It doesn't matter who did that to you. How are you going to deal with it? And then the methodology was exposing yourself slowly to it to reacclimate your system.
Exactly.
And I did it for a year, and it was very deliberate, very intentional.
So you relived some memories. So they kind of mapped out some memories that are bothering you, or situations.
Experiences. Yeah. And so I went from leading Mighty Oaks. I was very ashamed at the beginning to even admit to people where I was, because I'm running this national program. It's helping so many people with PTSD. But the one thing is, it may sound silly to other people, but to me it did. I kept a little silver bottle everywhere I went, and I didn't go anywhere without it. And it had an Ativan in it. And I would go years without needing it. But there's something about knowing that Ativan pill was there was a safety net, that if I had a panic attack come on, I could go to it. And being separate from that thing would cause me anxiety. And so that's the thing my prolonged exposure did, was I went from leaving it in my car and going on a trail run 1 mile away from it, 2 miles away from it, 3 miles away, then a 7-mile run away from it. Then went from leaving it in my car at the trailhead to leaving it at my house.
Yes.
And then over a year to where I didn't need that pill anymore. I traded that little silver vial for memorization of scripture. And so I tied it to my faith, and the biblical counseling tied to that prolonged exposure. And it really, after a decade of dealing with the panic attacks, the fear of panic attacks, it really freed me from that. But it was the prolonged exposure tied with my faith, those two things together.
I love, love, love that example, because this happens so often that there's just one piece that keeps all the symptoms locked in. And that one piece is actually an avoidance mechanism that feels like a control mechanism. So you holding that Ativan, carrying it with you, felt like you were maintaining control. But actually, we call that a safety behavior or an avoidance behavior that was keeping all those symptoms locked in. And you could tell, because whenever you didn't have it or forgot it, you had anxiety, right? And so by targeting that, and we call it systematic desensitization, step by step. We also call it gradated exposure, graduated exposure, because you're doing it step by step by step. Like you said, 1 mile that you'd go without it, right? And then, okay, now your nervous system learned, I went a mile, I didn't die. I didn't have a panic attack. Maybe this is okay. Then you went 2 miles. That is nervous system training. And that's why prolonged exposure and exposure therapy in general is so effective. Just there's not a lot of therapists who are trained in it or trained in it well. And I think that that's the issue. Sometimes people have bad experiences with it.
Well, they said this lady, particularly that led me through this program, she said at the VA that only 10% of the psychiatrists, am I saying it right?
Psychologists,
at the VA, only 10% of them had training in prolonged exposure, but everyone else was cognitive therapists.
Exactly.
And I could tell you from the work that I do at Mighty Oaks Foundation, and the thousands and thousands of veterans we treat with anxiety, depression, acute stress, PTSD diagnosis, like major issues, the approval rating of the VA mental health system is, it's like, I mean, I think the statistics, the actual stats are like 70% disapproval rating of the VA.
I know.
I'm just saying,
it's tough.
These things that I'm sure it's not accurate, but
I was a psychologist for the VA for many, many years. I did a lot of my training there, and I think it's understaffed and people are getting, frustrated. It was hard. I would say it's very hard to be there. I think it's also, people get forced to see you. So you're not, people aren't choosing to see you sometimes. And sometimes people maybe aren't motivated to get better. There's a lot of complexities in there. So the burnout rate is very high.
Yeah. Well, I mean, if you should have a personality connection with anyone, it should be your therapist, 100%. Right? It should be the person who's going to,
Yes. And sometimes, like in any profession, right? Sometimes you just can't find the person for you. Yeah. So I always encourage people to find, and search for many people.
I'm not giving them a haircut by somebody I don't like, much less
Exactly. A therapist. I know it's very important.
Yeah. So, can you give some other examples of maybe people, like scenarios you've seen in people you worked with that you've done prolonged exposure with? Mm-hmm. I'm kind of curious to hear examples outside of myself.
Oh, absolutely. So I get a lot of specialized referrals for victims of childhood sexual abuse. So kidnapping victims or somebody who was just finally taken out of the home that they've been abused in. And so we have to do exposure therapy with some of the memories that they have because, what gets locked into the nervous system is just so tough. And many times people don't have anybody to talk to about what happened to them. And the shame is so heavy. So just by starting to tell the story, the exposure therapy starts to work. And then we map that out. We create hot spots. So sometimes they cannot tell me something. And I say, you don't have to tell me. In fact, you never have to tell me. But maybe if you tell me a piece of it, you will learn that it's safe. And then we can add a piece onto that. And then maybe we can get to the full story. But if we don't, that's okay too. And every client that I've had in all of these years, they've all told me the full story. And it's been a weight off their shoulders. So that's an example of exposure therapy, is just telling the story and then telling the story enough times to where you lose that emotional locked in component of it. I also treat people for phobias, elevator phobia, speaking phobia, driving phobia, flying phobia, all of the phobias. And I do virtual reality headset. So in real time, and my client can be at their home in another state, and then I control what they're seeing on the virtual reality headset. And so I can create situations and add levels of difficulty into it. I had a patient who, a pretty high performing professional who had a plane phobia and hadn't flown on a plane for 12 years. And then finally needed to take this trip, found me on Google because I listed it on my website and just said, do you think I could ever get over this? And I said, yes, give me 6 to 8 sessions. And he said, no way. I said, yes, shipped him a headset. And then sure enough, in 6 to 8 sessions, he, flew across the world. And so I think that exposure therapy, it's evidence-based, done in the right way. It unlocks a ton of that trap that anxiety brings. One more example for panic attacks that people don't realize. Panic attacks, first, most panic is flagged in the emergency room because people think they're dying, having a heart attack, or going crazy, right?
Yeah, I've been in the emergency room several times. Blood pressure 200 over 130. I'm like, I'm having a heart attack.
Because it's real. No. Your body is actually taking over, right? Anybody, again, who's had a panic attack, you know what that feels like. And it's destabilizing. It's incapacitating, right? So it gets flagged in the emergency room. When people get sent to a therapist, most therapists, they don't exactly know what to do with panic. And so they teach slow breathing. We did slow breathing to get y'all's heart rate down at the beach today, right? So that slow breathing is great for starting to focus on a mission. But when somebody has panic attacks, slow breathing is actually going to have the opposite effect. It might have a positive effect in the beginning, but very quickly, if panic symptoms take over and you try to slow breathe, there's no way in hell that's going to work.
No.
And now they feel even more powerless, even more terrified, and the panic gets rooted in even further.
You'd have to catch it way in advance before.
Yes.
Once it starts going, then.
Yes. Yeah. So slow breathing is not an evidence-based treatment for panic. And I try to say that as clearly as possible because there are so many therapists who are doing that. The evidence-based treatment for panic is what we call interoceptive exposures. So intero means inside. Septive is how we perceive. Exposure is bringing up the the difficult thing, right? So what we do with interoceptive exposures is we bring up the sensations of panic and we sit with them over and over and over until they finally say, it's okay to be uncomfortable. I'm not scared of being uncomfortable. An example of that is the breath hold. So I train my clients to hold their breath beyond 60 seconds in a therapy session if they have panic or anxiety, because it teaches them to tolerate distress. It teaches them not to be scared when their body starts to do a thing. It teaches them to just roll with the uncertainty instead of reacting to it. It's a frontal lobe bench press, if you will.
Because most people don't, when you're having panic attacks, you don't know why you're having a panic.
Yeah.
I mean, maybe it's a symptom of a traumatic event, but in that moment of a panic attack, you couldn't say why you're having it.
And in fact, the criteria for panic disorder has to be that you have panic attacks out of the blue.
Yeah.
It can't be triggered by, a dog or driving the car or something acute. It has to be, I don't know what happened. It just came out of the blue. That's panic because your system is just throwing it at you and we're just not sure why.
Yeah. And
there's a sensitivity to it.
And then you become so fearful of the symptoms that you induce a panic attack.
Yes. In fact, there's another term for panic and it's called fear of fear. So you're so scared. There's a specifier with panic disorder called agoraphobia, where you're scared of being out, like at a restaurant at a table, because you won't be able to escape to safety. That's agoraphobia. So people stop driving, people stay at home because having a panic attack, really sucks. And to have it in front of people and not be able to escape a movie theater is almost unbearable for people to think about.
Yeah, it is absolutely terrible. So being on the subject of panic attacks, I mean, if someone's listening and having them right now, like, what can they do? Like, what do you do? Like, with the treatment you talked about?
So go to psychologytoday.com.
Okay.
Go to the therapist finder tool, put in your zip code. It actually doesn't even, we can see a therapist over telehealth just in your state, right? So you can just put in your state. Then you want to select all the criteria and you want to select somebody who has, I always say, click the box for trauma, PTSD, and exposure therapy, because trauma and PTSD, it's harder to get that type of training. But so if you select those boxes, then usually it's going to filter out therapists.
Even if you're not diagnosed with that, just selecting those boxes.
I recommend that. Yeah. Because a therapist who's been trained in PTSD is trained in evidence-based treatment for anxiety. But a lot of therapists say that they're trained in anxiety because it's just a catch-all bucket, but they probably don't have evidence-based treatment training. So I always say check the box for trauma and PTSD, because that means somebody has really done specialized training in anxiety and stress spectrum disorders. And then check the exposure therapy box. And then ask good questions, How much training do you have in exposure therapy? Do you offer interoceptive exposures for panic attacks? And if they know what that is and they can give you an example, you got it.
In those early stages, are you totally against medicine when people are first experiencing panic attacks? I mean, obviously, if you go to emergency room, they're going to calm you down with the sedative.
Xanax,
Ativan, something like that.
Yeah, the first thing I recommend my patients do is get a blood draw to see if their hormones, chemicals, thyroid is out of whack, right? Because if something like that is out of whack, there's nothing that we can do that's going to fix that. So number one, medical health and blood draw. Number two, if they are in acute distress, and I'll often see somebody after an acute trauma where they are just truly not sleeping and then they aren't able to work, and now their identity of being a person who performs in the world is being crushed, I do recommend medication. Medication can be a really good reset to just get a little bit of sleep and start to regulate the nervous system. Because if the nervous system is so dysregulated and all your biorhythms, like your circadian rhythm, your leptin and ghrelin, the hunger and satiation that you experience.
Makes it really hard to get well.
Yes. If all that's out of whack and then you're like, I'm not okay, it's very hard, exactly, to take those steps. So I am a supporter of medication to stabilize somebody. But to be on it for the long term, no, because that's where cognitive behavioral and existential therapy can really help.
That's where I'm at with it. Use the medication to get stable. It has its place. And then once you're stable, then do the hard work to face it, work yourself off the medication and through the trauma to gain back control of it. That's kind of where I'm at.